The proper room setup is achieved by utilizing the concept of optical correctness and the establishment of an operating suite ergonomic strategy. Optical correctness is achieved by placing the monitor opposite the surgeon with the operative site between. Instrument directional stability is further assured by the surgeon never looking over their shoulder while operating. Employing this strategy, the surgeon should be placed on the right-hand side of the patient, and the camera person should be placed on the right-hand side of the surgeon. If the availability of personnel allows, a first assistant is positioned opposite the surgeon. However, if personnel is limited, the camera operator transfers to the opposite side of the table in the position of the first assistant, and the scrub nurse then moves into the camera position. This is a picture of the abdomen showing the trocar site placement in relation to the jejunoscopy tube exit site. This is the first site that must be identified before you can properly position all of the trocars. The general location is usually the left upper quadrant, at least 2 finger breadths lateral to the rectus muscle sheath, and 2 to 3 finger breadths from the level of the umbilicus. Do not make any initial incisions at this site until after all of the trocar placements have been accomplished. A transverse incision 3 to 4 centimeters in length is then performed at the tube site. Hemostats are used to clear the subcutaneous tissues until the fascia is identified. A clearing 2.5 by 2.5 centimeters is made over the fascia. This will serve as the insertion site for the tube and the exit site for our fixation sutures. Now you can see, with the non-dominant hand, the operator coming in and lifting up the transverse colon and displaying the area where the ligament of Treitz resides. Notice how, with the reverse Trendelenburg of 30 degrees, all of the small bowel has now gone into the pelvis. The operator lifts up the transverse colon with the non-dominant hand, and the dominant hand, in this case the right hand, can readily identify the ligament of Treitz. This identification of the ligament of Treitz is paramount if you are going to have proper placement of the jejunostomy tube. The next step is to now move 30 to 40 centimeters away from the ligament of Treitz in order to identify the entry site of the jejunostomy tube itself. The endoclose is placed through the apex of the diamond suture placement pattern. This helps to localize exactly where the suture should go on the bowel. Here we have the endostitch coming in. Its advantages are readily apparent. Instead of having to go through the tortuous manipulation of the needle and needle holder to perform intracorporeal suturing, the endostitch itself establishes the suture through the tissue with one pass. The endoclose captures the suture in an aircraft carrier landing-like fashion. The endo shears are brought in to cut and release the suture from the jaws of the endostitch. At this time, there must be a hemostat ready to grab the suture to hold it in place as it exits. Now, pass the endoclose back into the abdomen very close to the previous entry site. The endoclose then repeats the aircraft carrier-like technique and removes the suture from the abdomen. This is repeated until a diamond-shaped suture pattern has been established. This diamond pattern is approximately 1 inch long and 1 inch wide. Once this is complete, you have a hammock configuration formed as you see here. The needle is inserted into the bowel in the middle of the diamond-shaped suture pattern. The guide wire is then put in place, and the introducer and tearaway sheath is introduced into the abdomen and, subsequently, into the bowel. This can be assisted by supporting the abdominal wall with the non-dominant hand instrument. We suggest that the apex of the triangle be lifted close to the abdominal wall to help support the atraumatic insertion of this introducer tearaway sheath complex. Once that is done, the tearaway sheath is removed, and the sutures are tied so that we have a standard jejunostomy tube placement.